You're listening to Medscape's In Discussion series on endometrial cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ursula Matulonis, Chief of the Division of Gynecologic Oncology at the Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. She is the first recipient of the Brock Wilson Family Chair at the Dana-Farber Cancer Institute. She co-leads the Gynecologic Cancer Program within the Dana-Farber Harvard Cancer Center, the Ovarian Cancer Specialized Program in Research Excellence, SPORE grant, from the National Cancer Institute within the Dana-Farber Harvard Cancer Center, and an NCI P01 program project grant that is focused on targeting replication stress in high-grade endometrial cancers. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
I'm Dr. Ursula Matulonis. Welcome to Season 1 of the Medscape in Discussion Endometrial Cancer podcast series. Today, we'll discuss what's new in targeted therapy for endometrial cancer. I'd like to first introduce my wonderful guest, Dr. Joyce Liu. Dr. Liu is a medical oncologist who specializes in gynecologic cancers and serves as the Associate Clinical Research Officer for the Dana-Farber Cancer Institute in Boston, Massachusetts, as well as the Associate Chief and the Clinical Research Director for the Division of Gynecologic Oncology, also at Dana-Farber. Joyce, welcome to Medscape in Discussion Endometrial Cancer podcast.
Thank you so much for having me.
So, a lot to talk about today, and really kind of just starting off with your thoughts about uterine cancer. This is a cancer that really, truly is an unmet clinical need right now in the United States, with both increasing incidence and mortality. And in 2024, there will be nearly 68,000 cases diagnosed per year in the U.S., with increased mortality across all racial and ethnic subgroups, which is particularly notable in Black women. Do you have any thoughts about why the incidence and mortality are both on the rise?
Ursula, this is such an important point. Like you were saying, uterine cancer actually is one of the very few cancers in the U.S. where both the incidence and mortality are rising. And in fact, you're talking about the number of cases. It's projected that in the coming few years, uterine cancer is going to overtake ovarian cancer as the fifth leading cause of cancer death for women in the U.S. And already it is the leading cause of gynecologic cancer death for Black women in the U.S. You know, it's really interesting to think about it because I think the reasons behind this rise in incidence and mortality are probably quite complex. You know, for a long time, we've talked about uterine cancers being these hormonally driven cancers, and we know that the risk for hormonally driven cancers can rise as body weight increases. And so one thought has been just like the general incidence of uterine cancers is increasing in part because our population is getting heavier and more prone to obesity. But what's complicated about this is that when you think about the uterine cancers that are most hormonally driven, they're the less aggressive, lower grade endometrioid cancers, and the ones that are rising in incidence the fastest are actually the high grade ones. And that's especially true in Black women, and that's also likely contributing to the increasing mortality we're seeing with these uterine cancers as the high grade cancers are more aggressive and in general have poor outcomes. You know, one of the things that I think about with this is that where these high-grade uterine cancers are the ones that are most increasing in incidence, it tells us that there's questions about whether hormonal or metabolic signaling drive these cancers in ways that we haven't yet fully understood. Other things that people have talked about are that, you know, high-grade cancers do increase with age. And as our population is aging and as elective hysterectomies aren't being done as often, that's another risk factor for why we're seeing increasing incidence of these cancers.
Those are all really great points. Clearly, we also need increased funding from our foundations, but also especially from the National Cancer Institute, which I think is hopefully going to start to be addressed. So for patients with advanced endometrial cancer who come in an initial diagnosis, or for those patients who have earlier disease but then eventually have relapsed cancer, tell us how you decide on treatment for a patient with advanced endometrial cancer and what factors go into these decisions, specifically genetic factors and cell surface marker expression.
Yeah, this is a good point for discussion. I mean, if you had asked me this a few years ago, I think the answer would have been pretty straightforward, you know, in terms of how I would think about the treatment for advanced or newly recurrent uterine cancers. But as our knowledge of the uterine cancers has increased, I think we've really come to recognize that, like other types of cancers, we can't just sort of lump all of our uterine cancers together and say they're just like one type. If you think back to it, the Cancer Genome Atlas genome-wide analysis of endometrial cancers was published over a decade ago now. And I think we finally have really recognized that each of the molecular classes from that TCG analysis has prognostic implications that really complements our traditional understanding of the different uterine cancer histologic types. So for me, when I think about these patients coming in with newly diagnosed or newly recurrent advanced uterine cancers, the first thing I really want to know, as I'm thinking through their treatment options is the tumor's mismatch repair or MSI status. For patients with those mismatch repair deficient or MSI high tumors, we now have the data from the RUBY and the GY018 studies that have really demonstrated this really significant improvement in outcomes with the addition of a PD-1 inhibitor to standard carboplatin and paclitaxel chemotherapy. The hazard ratios for PFS in these trials is like 0.3. And so, I really think about this. In the U.S., dostarlimab is now FDA approved for the indication of treatment together with chemotherapy followed by maintenance dostarlimab. In these patients, the FDA just set up PDUFA date for pembrolizumab. That's going to be in June of this year. And both of these regimens, carboplatin, paclitaxel, and pembrolizumab followed by pembro maintenance, carboplatin, paclitaxel, and dostarlimab followed by dostarlimab maintenance are already on the NCCN compendium guideline listings. So I think this is a can't miss. If a patient has a mismatch repair deficient tumor, then they should be getting a PD-1 inhibitor in addition to their standard carboplatin paclitaxel chemotherapy. The other big marker that I like to know about immediately for my patients with advanced or newly recurrent disease is HER2. And it's the HER2 expression status on the surface of the tumor that you can see by immunohistochemistry and then looking for amplification. There was that small randomized phase 2 trial led by Amanda Nichols-Vader and Alessandra Santini a number of years ago now that showed that the addition of HER2-directed monoclonal antibody, trastuzumab, to carboplatin and paclitaxel in these patients who had HER2-amplified uterine serous cancers improved outcomes compared to carboplatin and paclitaxel alone. The Energy Cooperative Group is currently conducting a large randomized phase 3 trial, Energy GY026 study, that's looking at the testing of adding trastuzumab or trastuzumab and pertuzumab, which is another HER2-targeting antibody, to those HER2-positive uterine serous cancers and carcinosarcomas. And so that's a trial. That's an option for those patients. And then for those patients who can't enroll to the trial, I'll admit I've actually extrapolated these results to the P53 mutated tumors in general. And I think of these as being very serous-like and share biologies to the uterine serous cancers. And so patients who have HER2-amplified P53 mutated tumors, I tend to add trastuzumab to the carboplatin and paclitaxel chemotherapy.
Those are all really fantastic points. A couple other comments about kind of what tests are ordered up front. So sometimes estrogen receptor, progesterone receptor, do you think that's necessary for grade 1 endometrioid tumors? And then secondly, how do you incorporate next generation sequencing and when do you order that?
Yeah, so I order estrogen receptor and progesterone receptor testing because I want to understand sort of that status, especially for the low-grade endometrioid cancers. I think there's a lot of debate about, is there a role for hormonal maintenance for those patients who have ERPR positive tumors where you're really worried that cancer might come back for somebody with an advanced stage disease and you're not quite sure what to do with them. We don't have data for it. I like to have that information. If those patients have recurrent disease, I feel like it helps me think about what my next sort of steps are going to be. I do next generation sequencing at the time of diagnosis for patients with advanced stage tumors. It's part of now incorporated into the staging schema. The new 2023 FIGO staging guidelines actually do include this. And we know that has prognostic information. I think that it has a lot of value as we're thinking both about the immediacy of treatment, but also I like to have that information available to me if that patient's cancer comes back and I'm starting to think about clinical trial options.
That makes sense. So you've already talked about the RUBY study and GY018 and how you incorporate immune checkpoint inhibitors into patients with advanced mismatch repair deficient cancer. Can you talk about what you think the role of checkpoint inhibitors are for mismatch repair proficient tumors with chemotherapy, specifically carboplatin Taxol, and where you now see the combination of pembrolizumab and lenvatinib fitting into treatment?
This has been a topic of a lot of hot debate. What do we do? I mean, I feel like with the patients with mismatch repair deficient tumors, the answers are so clear. The data are so positive. The Ruby and Energy GY018 studies in patients with mismatch repair proficient tumors, you still see some degree of activity. It's just not as profound as it is in patients with mismatch repair deficient tumors. And I think it's really opened the door to this question, a gray area of what to do. Ruby's presented a exploratory analysis based upon the TCGA molecular subgroups. And I actually have to admit, when I saw it, I was a little bit surprised that in the mismatch repair proficient cancers, it was actually the P53 mutated subgroup that seemed to have the most benefit from the addition of dostarlimab to chemotherapy. I mean, this is an exploratory analysis, it's a subgroup analysis. So I think we really need to see if this is going to be corroborated in future trials and analyses to say these are the patients we think are really going to benefit. Neither the Ruby nor the GY018 regimens is currently FDA approved. The PDUFA date that I mentioned earlier for pembrolizumab does include the mismatch repair proficient tumors, so we will see what the FDA thinks. But they're both in the NCCN guidelines irrespective of mismatch repair status. So we really, in the US, we have the possibility of offering them to patients. And so I think, again, that sort of gray zone exists. What I'm doing right now for my patients with advanced or recurrent mismatch repair proficient cancers is I'm talking with them about the data. I feel like it's worth a conversation to recognize that there's some degree of PFS benefit. We don't know that there's truly OS benefit. And it's weighed against the side effects, the potential side effects of immunotherapy. I've had some patients who have had some really, truly life-altering complications from immunotherapy, and we can't predict who those people are going to be. And then there's also the cost of being on maintenance immune checkpoint therapy for an additional 2 to 3 years, sort of psychological, the time, the effort, all of those components to it. And so I talk with patients about it. I kind of get a sense of how they feel about it, and we do a shared decision-making about whether it's worth it for them to do immune checkpoint therapy.
I think that makes sense, and that's what I do as well. I think you're right about the potential for significant toxicities, and it's a relatively low risk, but it definitely happens. And, Keynote 775, this is now older data, and the LEAP 001 trial, which is newer data, tries to see where lenvatinib pembro kind of fits into things where, 775 shows superiority versus chemotherapy, but the LEAP 001 trial poises that against chemotherapy for newly diagnosed advanced disease. Thoughts about where this combination now fits?
Yeah, I think we shouldn't forget about this combination. I'm not giving immune checkpoint therapy to all of my patients in the sort of upfront setting. And remembering that the patients with stage 3 disease that's fully resected, many of them were not included in the GY018 and Ruby trials. And so we actually don't necessarily know that immunotherapy is the right thing to do in that setting either. And so there are these patients who have recurrent disease who are immunotherapy naive, they're immune checkpoint inhibitor naive. And for me, that's where lenvatinib pembrolizumab really still plays a role. It's the FDA-approved regimen. We have a trial, Keynote 775, that shows it's better than our chemotherapy options in that setting. And so I absolutely think about LenPem for those patients. I think the unanswered question to me is for a patient who has had prior immune checkpoint therapy, whether LenPem is still going to have value in that setting. And I think that's something we just don't know.
I want to shift topics a little bit to talk about antibody-drug conjugates. These agents are certainly poised to make an impact, or probably having an impact already in endometrial cancer treatment. You've done a lot of work on these agents. So how are you using antibody-drug conjugates in your practice right now for patients with endometrial cancer? And what targets and payloads are you especially excited about?
I love antibody-drug conjugates. I think right now in practice, truthfully, trastuzumab deruxtecan, or TDXD, is really the only ADC that we have clinical access to right now, sort of outside of a trial that I think is fully relevant in the endometrial cancer space. It targets HER2. We had the PanTumor02 study that showed that TDXD had really impressive activity in the HER2 moderate or high expressing endometrial cancers, IHC 2+ or 3+ with a gastric HER2 scoring criteria. And so based upon those data and the fact that now the NCCN has T-DXd on its compendium listings, so I have access to it. And then the FDA just earlier this month granted a disease-agnostic accelerated approval for T-DXd in HER2 IHC 3+ cancers. I am testing HER2 IHC now in all of my patients with recurrent endometrial cancer. I do consider trastuzumab deruxtecan therapy for any patients with HER2 IHC 2+ or 3+ cancer who have received, usually I think of them at least having received carboplatin and paclitaxel chemotherapy, but I'm really thinking about trastuzumab deruxtecan for those patients. I think there's some caveats. We don't really understand HER2 expression and its sort of life cycle as well in endometrial cancer as they do with breast cancer. So, the heterogeneity, how does it evolve over the treatment course and the lifespan of uterine cancers is something like I think we don't know quite as well, and we have to learn more about.
I had a conversation with Katie Moore in an earlier podcast where we really talked about the toxicities of this agent and what to look out for trastuzumab deruxtecan, around lung toxicities, bone marrow suppression, etc.
The ADC space is going to be really exciting. So you were asking about other targets. I think that, folate receptor alpha, TROP2, B7H4, there's all sorts of agents that are currently being developed there. There's other HER2 targeting ADCs that are being developed in the endometrial space. I mean, most things are with topo-1 payloads or maytansinoid microtubule targeting payloads, but I think it's going to be very exciting to watch this space evolve in the coming years with therapy coming to our patients.
Totally agree. I want to congratulate you on all the work that you've done on testing a novel type of therapy called the WEE1 inhibitor for patients with uterine cancer, specifically high-grade uterine cancers, uterine serous cancers, endometrial carcinosarcomas, as well as your newly funded program project grant that targets replication stress in high-grade endometrial cancers. Can you talk about what exactly replication stress is and why it's important in endometrial cancer, specifically high-grade endometrial cancers?
Well, thank you so much. So full disclosure, it's a shared PO1. And so, it's been such a privilege and a really rewarding experience to get to work with you on it. Replication stress is really funny. I was just at the AACR meeting and it felt like replication stress was like one of these major themes that ran throughout the entire conference. And maybe I'm just like super sensitized to it now. And whenever it's discussed, I'm like, oh, this is the most important thing. But it just felt like it was everywhere. Broadly, from a conceptual perspective, replication stress is this phenomenon where DNA replication is slowed, characterized by the slowing or stalling of replication fork progression and DNA synthesis. But it turns out that replication stress, that's conceptually what it is. It's an amazingly complex phenomenon, and there are just tons of causes for replication stress. For example, one of the most common causes for replication stress is the presence of unrepaired DNA lesions, because these are going to cause a barrier as the replication fork is progressing, and they have to be repaired for replication to continue. So the fork has to slow down or stop. There are other causes, and one of those is actually oncogenes. They can drive replication stress. They promote increased origin firing, and that depletes the dNTP pool, so you just don't have enough nucleotides to actually do DNA synthesis. They can also cause what are called replication transcription collisions, where the replication fork collides with the transcription machinery. And so those make it such that replication has to slow as well. So those are just two examples. There's a ton of them. In high-grade endometrial cancer, when we were doing this work, what we identified was that, high-grade endometrial cancers have a number of molecular features that really suggest that they're under high replication stress. They have p53 mutations, which abrogate the G1S checkpoint. They have a lot of mutation or amplification oncogenes, such as KRAS or MYC. They have alterations in other cell cycle modulating genes, such as CCNE1, which is cyclin E, or RB1. And so that these cells that are under really high replication stress, they become really dependent on the control of the cell cycle checkpoints because they need more time to allow the DNA to replicate before they enter mitosis. Otherwise, if they go into mitosis and their DNA is not appropriately replicated, they can have mitotic catastrophe in the process of the cell division. So when we started our work with WEE1 inhibitors, we were hypothesizing that these high-grade endometrial cancers, the uterine serous cancers, would be highly dependent on WEE1, since WEE1 is a really key regulator of the G2M checkpoint. As you know, in our trial of adavosertib, we saw a significant activity with almost 30% of patients having a response and almost half of those patients being without growth of their cancer for at least 6 months. Adavosertib's sadly no longer being developed clinically, but there's a number of WEE1 targeting assets in development. There's a drug called azenosertib that's in clinical trials in ovarian and uterine cancers. And then I think there's other cell cycle regulated proteins that are going to be very interesting to think about in the replication stress high tumors. We've seen drugs targeting ATR, PKMYT1, CDK2, and they're all in active development in this space.
Thank you. There's a lot going on in that sphere of replication stress. So I just want to, again, pivot to yet another type of therapy, but certainly connected around DNA repair, the role of PARP inhibitors for ovarian cancer. You've run a number of trials focused on PARP inhibitors for ovarian cancer and really are an expert in the field of this class of drug. What do you think about the use of PARP inhibitors for endometrial cancer? And do you think there's a role for this type of therapy for patients with endometrial cancer?
What a good question. It's going to be interesting to see this space evolve, right? Uterine serous cancers or uterine cancers in general are just not the same as ovarian cancers. In ovarian cancers, we have this very clear-cut rationale for PARP inhibition, which is the presence of homologous recombination deficiency. A lot of that's BRCA, but there's other causes as well. In endometrial cancers, it's not as clear-cut. When you look, even in P53 mutated endometrial cancers, which look the most like high-grade serous ovarian cancer, when we've looked at various ways of trying to assess for homologous recombination deficiency, the frequency of that is just not as high as it is in high-grade serous ovarian cancers. And yet when we look at these trials, so now we have some trial data of looking at PARP inhibitors in endometrial cancer. And I think we need more time and we need more information to tease out those results. There have been 2 PARP inhibitor maintenance trials that are phase 2 trials, the Etola trial, which was with olaparib, and then a trial that was run out of University of Colorado with Brad Clark. And they showed slightly inconsistent results. One showed benefit, one didn't. Tried to tease out the biomarkers for that. And then, of course, we have the DuoE trial, which is very intriguing, looking at putting durvalumab together with chemotherapy, followed by durvalumab maintenance, durvalumab with chemotherapy, followed by durvalumab and olaparib maintenance, and comparing both of these experimental therapies to the control arm of just chemotherapy in patients with advanced or recurrent endometrial cancer. The challenge with that study is that numerically, the durva and olaparib arms, or the arm that has the PARP inhibitor, did the best. But the study wasn't designed to compare the 2 experimental arms against each other. And so we don't quite understand, is olaparib really giving us a lot more bang for our buck? Is there a synergy there? And in addition to that, I think that it would be really nice to know, are there true populations that benefit? I don't think all endometrial cancer patients are going to benefit from the addition of a PARP inhibitor. It's probably still going to be a select population, but the biomarker may not be the same as what it is in ovarian cancer. And that's where we have work to do.
Right. And that biomarker has not really been identified yet at all. And then secondly, I think what we've seen in phase 3 trials of PARP inhibitors in ovarian cancer, where there's clearly a very clear rationale for these PARP inhibitors, especially in BRCA mutated patients, is that you really need to look at survival and make sure there's no detriment in OS results. And so I agree with you, there's a lot of work to be done in uterine cancer. So I'm going to end our podcast today asking you about what other therapies for endometrial cancer are you excited about right now?
I think it's a really exciting time in endometrial cancer. It's been really rewarding to be in this space and to see all of the developing therapies in a place where we had nothing for years and years and decades. In addition to the therapies we talked about, the ADCs, targeting replication, stress, and DDR, I think there are advances being made in improving hormonally directed therapies. We didn't talk a lot about that. We talked a little bit about ER and PR testing, but as you know, there's studies. Panos Konstantinopoulos, one of our colleagues here, has led work adding CDK4/6 inhibitors to aromatase inhibitors in endometrial cancer with some really promising signals of activity. And I think there's more work to be done there. Another area of development that's not quite as mature, but I think could be very interesting, is the area of cellular therapies. On the surface of it, at least from what we've seen, endometrial cancers seem to be much more responsive to immunotherapies than ovarian cancers. even the ones that are mismatch repair proficient. So this could be a space where the evolving cellular therapy field, as it's moving into the solid tumor space, could be, something that could be a difference maker.
Joyce, what a great conversation. So today we've talked to Dr. Joyce A about a number of different new therapeutics and therapeutic strategies for our patients with advanced endometrial cancer, including antibody drug conjugates, where is the best use of immunotherapy, drugs that are targeting replication stress. We talked about drugs that also target estrogen receptor and positivity within endometrial cancer. So really, we've covered a broad range of topics here. So thank you so much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on endometrial cancer. This is Dr. Ursula Matulonis for the Medscape in Discussion Endometrial Cancer podcast. Thank you so much.
Thanks for listening to Medscape's In Discussion Endometrial Cancer podcast series with our host, Dr. Ursula Matulonis. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on endometrial cancer.